Good morning, good afternoon, and good evening, everyone. Thank you so much for joining the ACNS ISMIN webinar today. Today, our chair is Professor Kimura, who is the Associate Professor of the Department of Neurosurgery of the Kobe University Graduate School of Medicine in Kobe, Japan. Our first speaker of today is Professor Nora Stone-McGuire, who is Assistant Professor of the Department of Neurosurgery, the University of Wisconsin in USA. His topic today is flow-based management of AVM. Our second speaker is Professor Xu Yinghe from China. She's the Director of Neurology Center and Director of the Cerebrovascular Units of the Second People's Hospital of Guangdong Province in China. Her topic is complex AVM cure through transarterial and transmitter approach. Today, we'll also have our one-point lesson from our chair, Professor Kimura, talking about the usefulness of CFT for understanding cerebral aneurysm or properties. Our discussion today is Professor Ezra, who is the Chief of the Neurovascular Therapy Center of the Department of Neuro Faculty of the Medicine of ASEAN and in Indonesia. Our second discussion is Professor Esma, who is the Head and Senior Consultant Neurosurgeon of the Department of Neurosurgery in Malaysia. He's also the Head of the Ministry of the Health in Malaysia. To moderate a section with me, we have Dr. Hui Pham, Dr. Biswas, and Dr. Atik. So without further delay, shall I pass the floor to our chair, Professor Kimura?
Yeah, thank you, Ben, for your kind introduction. It's my great honor to have chair this fantastic webinar today also. I'm deeply appreciate again Professor Okato and Professor Liu and Roger and Ben as my colleagues. Thank you. And today, my first speaker was also mentioned, Professor Laura. She will talk about the flow-based management of arterial venous malformations. So I'm looking forward to hear the lecture. So please, Professor Laura, please start your presentation when you're ready. Thank you.
Thank you so much. I'll go ahead and share my screen. Okay.
Okay. Oh, slideshow, please. Okay, thank you.
Yes.
Okay, very good. Well, thank you so much to everyone for having me. And I very much appreciate this honor to be able to share some of the research that I was able to do during my fellowship and during my residency at the University of Illinois at Chicago, mostly under the mentorship of Dr. Charbel and Dr. Alaraj. Some of the papers that I'll be discussing are from work that I did with them, but some of them is from work that they had done before me as well. But I am going to be talking to you today about the flow-based management of arteriovenous malformations. But specifically what that means is using quantitative MRA to better understand AVMs and then help to facilitate their resection. As you mentioned, I am a professor at the University of Wisconsin. I'm an assistant professor there, so I've been there almost a year now. And my specialty is in vascular neurosurgery. So for today, I'll just go through the measurement of flow, specifically with quantitative MRA, just to give you a brief introduction to the type of technology that we use for this. A little bit of information about AVM assessment and insights that we can gain about AVMs with quantitative MRA. And then the flow reduction strategy, which is what we used in my training at the University of Illinois at Chicago. So the quantitative MRA that I was used to and that I trained with is something called NOVA. This is a system that was developed at the University of Illinois at Chicago. And essentially, this uses both time of flight and phase contrast techniques in order to capture flow information. And so the time of flight is what provides the high resolution vascular anatomy, either in 3D or 2D modes. And this gives you the structural insight into whatever disease that you're looking at. Because, of course, today I'll talk about AVMs, but we use this for multiple different types of diseases too. Phase contrast specifically is the method that was used to give the non-invasive measure of vascular velocities and the vessel cross-sectional areas that estimate the flow rate, which is important, through the specified vessels that you give the program. And this is how you monitor for disease progression, you monitor for changes in flow after embolization sessions, for instance, and it helps to characterize the disease. So these pictures that are on the right-hand side demonstrate specifically here, show the type of a flow map that might be generated from the software program, which will tell you the specific vessel as well as the flow that's going through the vessel. This particular picture is actually one that's taken from a Diamox challenge that is done to look for hemodynamic reserve, which is not something that you would do for AVMs, but that is something that can be done with this software also. Where I am currently located at the University of Wisconsin, we've been developing our protocols there. This is something that was already there before I started PC Viper, but then we've been working to build it into other uses for vascular neurosurgery. And so this also is a way to capture flow measurements through cerebral vasculature. And so this is also time-resolved phase contrast with MRI. A three-directional velocity encoding, which is a bit more advanced than the NOVA software. Spatial resolution is very good, less than 1 millimeter. And what's very nice is that this can, the images are acquired in all planes within one session and processed after acquisition. And so it gives you a lot of freedom to get flow measurements in different regions of interest throughout the vessels, even if you didn't initially identify a region of interest to begin with. I'm not going to go through this entire table, but just to give you a sense of the normal flow values, there is literature out there that tells you what the expected flow measurement should be through a given vessel within the neck and within the brain. And that these numbers actually do change with age. And so that's a normal process that is seen according to this study, that as you get older, the flow drops essentially throughout your brain in all different territories. So specifically about AVMs, I'll go through these papers relatively quickly so I don't go over time. But we use the quantitative MRA as part of the initial assessment, and then as part of our sequential monitoring as we do targeted flow reduction with embolization sessions. And essentially, once we get the AVM to a point where the flow has been lowered enough that we feel it's safely to resect, that is when we actually proceed with the resection. And usually that cutoff value is somewhere in the range of 100 cc's of flow through the AVM. So these flow measurements provide information for planning that intervention. So it's not just the flow through the arteries themselves, but the flow through the veins, and then also specifically high-risk features. It's very useful for that also. So draining vein stenosis and the impact of that on the flow within the AVM, and feeder vessel aneurysms as well. And these pictures are just to give you a sense of what this looks like whenever this, this specifically is the NOVA software that I mentioned initially. But this is how those flow maps might be presented for this particular AVM example. And so what you can see is that on the flow map, that the different vessels are all laid out with their corresponding flow measurements. And the way that the AVM flow is characteristically calculated is that you take the vessels on one hemisphere and subtract the vessels from the other hemisphere to give you that net flow. And that net flow is your AVM flow. Another way to calculate AVM flow is actually what is used in this example here, where if you have a single draining vein that is very easily captured, or even maybe just a couple of draining veins, then that would actually be the best assessment of the flow through the AVM. And so you can get a cut as just directly through that draining vein. And in this particular example, the flow that was caught on this MRA was about 500 cc's of flow per minute. So some of these features that I mentioned that you can find that we've researched on quantitative MRA. First off is this draining vein stenosis. So what have we found out is that flow is associated with venous intimal hyperplasia. And so that there's a significant relationship between the maximum vein wall thickness and the total AVM flow, as well as AVM flow per the draining vein and the mean intranidal vessel diameter. And so there's a significant association of draining vein stenosis between age, atherosclerotic risk factors, and this likelihood to develop the stenosis, which is an important feature when you're considering rupture risk. We've also done research on feeder vessel aneurysms. This is something that we have found that the aneurysms, the AVM feeder arteries that had aneurysms actually had similar flows, but smaller diameter. And so this suggests to us that the AVM feeders with aneurysms are a subgroup that the vessel remodeling cannot compensate anymore for the increased blood flow. We also found that the wall shear stress is significantly higher among the feeders harboring the aneurysms. So on to this flow reduction strategy. So what I mean by this is doing embolization of targeted feeder vessels to help reduce the flow in the AVM before resection. And we can check and see how much flow has been changed with this imaging. And the total number of pedicles embolized after multiple embolization sessions is most predictive of the final flow in this study that we looked at. Again, with this flow reduction strategy is that we did find that there was a reduced morbidity and mortality in targeted sequential flow reduction. And this was a study of 251 patients with 613 embolization sessions total. And they looked at these two different categories of patients, the traditional strategy where you embolize the feeder arteries and you achieve nidal penetration versus the flow targeted strategy, which is actually the ideal strategy according to our research, which is where you embolize the feeder arteries with an emphasis on high yield fistulas. So emphasis on fistulas, and you want to minimize the nidus penetration so that you can actually better facilitate the resection by preserving that pliability of the AVM nidus. And what we found in this particular study was that the major morbidity was seen in about 7% of patients, but that there is a disproportionate, or there was a difference between those with the traditional embolization, which was about 8%, versus this flow targeted strategy, which is 3.8%. So in this study, this also speaks again to this strategy that there's a larger decrease in flow per vessel per embolization session in AVMs that have the fistulas, which makes sense, but this was just a proof of that concept. In this study, we showed that the selective reduction of blood flow in larger and higher flow AVMs led to comparable intraoperative blood loss to those with smaller lesions that only underwent surgery as opposed to embolization plus surgery. And so it does help with blood loss during surgery as well. And then a few other points. I have a couple more slides left to go, but just that after embolization, we do see changes that happen within the AVM itself. And this is important so that you understand what's going on across time with these AVMs as flow changes. It diminishes, and wall shear stress and vessel diameter decrease as well, which is something that makes sense intuitively, but this is also evidence that supports that thought process. And this is my last slide that, this quantitative MRA is useful as well to guide your management, not just from a surgical standpoint. This was also something that we thought was effective when monitoring the response to treatment to SRS. And so this is granted a small study of only 12 patients, but we did monitor the way the flow changed over time after getting SRS. And ultimately, we could predict which patients were going to have obliteration of their AVM during the course of this study based off of flow. And then for this is just my last slide, just to summarize that quantitative MRA imaging does offer these unique insights into AVMs, possible risk of rupture due to high-risk features, and their response to therapy. And that this flow reduction strategy, specifically that flow targeted strategy, can be used to sequentially embolize and reduce blood flow in the AVM and facilitate that safer surgery. And here's my contact information with any questions.
Thank you, Professor Laura. It's a
Thank
fantastic,
you.
yes, very, very fantastic, technical, good point, and for the quantitative MRA using the for the prediction of the aneurysm, AVM treatment. So, can I give you one question first? So who it is I think there is a technical limitation in the institute. So what kind of condition to do this MRA, quantitative MRA? Just time of flight MRI can be used for this to use for quantitative analysis, or special condition to know to perform the quantitative MRA. Thank you.
Sure. I hope I understand the question, but I know that there are definitely limitations to having the quantitative MRA. First off, even if your institution has it, sometimes it can be very difficult in complex lesions like AVMs. So although I presented this research to you and where we were able to do it for AVMs, that it can be quite difficult with large AVMs with many feeders to it, many draining veins to it. It can become very difficult very quickly, given how complex AVMs can be. But I know that not all institutions have these, and so there are other ways that, and other research that has been done into different types of imaging. For instance, with mean transit time on angiograms, that is a surrogate way to help measure the amount of flow and flow changes that are seen on angiograms pre and post embolization. So that's a similar way to do that. And most institutions will have angiograms as a different way to measure and give a sense of how much flow is going through the AVM.
Okay, thank you. So, is there any question from the audience? Good point. Thank you.
Dr. Asmi?
Yeah,
Yes.
okay. Thank you very much, Laura. It is a very wonderful presentation. I think to me, this is the first time I've seen such a technology that I find that very useful, because with this technology, you can improvise the flow reduction strategy prior to reduction of AVM. As we know that the best treatment of AVM is a total excision. I think that would be the best, but complex AVM, a huge one, in ilequine area, sometimes you have to do stage embolization, and risk of surgery is very high. So by using this technique, I found that you manage to measure the flow and to the level where resection is very safe. I think that is very, very useful. But I have a couple of questions. Number one, can it be used in small children? Because you mentioned that the size of the vessels also have some different between maybe in children and adults. And number two, what are the best time actually you perform this before you decide for the resection? For example, after embolization, and when this investigation should be done, and then when would be the best time to go in after you have reduced the flow?
Oh, good question. So, regarding the size of the vessel and being able to measure this in children, for instance, the resolution of the MRA, both for the NOVA technique that I talked about, where I trained, as well as the PC Viper technique, where I currently work at the University of Wisconsin, both of those should have the spatial resolution to measure blood flow in very small arteries. And so the NOVA system, actually, you're measuring blood flow through like M2 vessels, A2 vessels. And so you calculate overall, and sometimes it's an estimate. It's not a perfect measurement, but it's an estimate of what the blood flow is and how it changes. So you may not capture a specific feeder, although you can. If it's a big feeder, you can at least get a sense of the global flow by getting the M1, M2, A1, A2 vessels. So you should be able to use it in children. For your second question, so we would, in my training, we would do, after every embolization session, we would follow that embolization session with a new measurement of flow. And ultimately, we would continue to do this until we reduced the blood flow up to around 100 cc's or less within the AVM. And that sometimes was not always achievable based off of the anatomy of the AVM, but that was our targeted goal range, so that we could bring it down low enough so that it would be much safer during surgery.
Yeah, the other thing is what type of MRI that you need for this software? Enough for 1.5 or you need 3 Tesla?
I think you can do it with 1.5. Don't quote me on that, but I'm pretty sure you can do it to 1.5 for NOVA. NOVA is ultimately just a software that is implemented in the MRI, and it's a protocol that's implemented. And so that, but 1.5 is, I believe, the what you have to have, but the images are better if they are, of course, 3 Tesla, but you can still do it at lower magnet.
And my last question is, after implementing this technique, so have you found that the completeness of resection and reduction of blood loss during surgery has significant impact in your experience, or any institution using the same technology?
Yeah, I mean, I was trained with this technique, and so for me, my opinion is going to be very biased with that. But for my experience using this technique, I honestly can't. To me, that is the way that I am programmed to think it is the safest, because I just see how effective it is. Because you just know so much more about what you're going into with surgery whenever you have these flow measurements, because this is a disease, this is a dynamic disease, and it changes throughout all the different treatments, the embolization sessions. And so it gives you a sense of what you're up against whenever you go into surgery as well. So I happen to think that it does make a big difference from what I've seen, but I know that is my bias because of my training.
But I believe it will be have an impact, because definitely, it's something like very objective assessment that you can use, rather than looking at, the angio alone. So I think this is a very good technology. I think we have a Ben Ng raising his hand. Maybe you have a question, Ben?
Yes, and thank you, Professor Laura, and also thank you, ASMIN, for this quick informative lectures. I have some details about, I want to ask about some details of this technique. And first of all, I want to ask, is there and for the MRI, is the contrast, the use of the contrast, gadolinium contrast, necessary for the interpretation, or because TOF sometimes can be reconstituted with in MRI without contrast? So I would like to ask about my first question is about whether the contrast is necessary for this interpretation. And my second
We
question.
did not use
yeah.
contrast. Yeah, so you do not need gadolinium for this.
I see. And my second question is about you find that the flow in the venous outflow is related to the venous wall intima hyperplasia. And I would like to ask about how can you know that in the hyperplasia in your study, is it measured by MRI or by pathology, or whether whether you measure it on MRI or by the pathology, and whether it would associate with the rupture risk?
So that's a good question. So with the study that I put into the PowerPoint presentation, that study was based off of just the presence of venous stenosis. And so, and the underlying cause of that is this intimal hyperplasia. But so that did not necessarily measure intimal hyperplasia specifically. However, there have been follow-up studies at the University of Illinois that looked at vessel wall imaging. And so that would actually use contrast, but the MRI with contrast. And the vessel wall imaging actually does look and see if there's, inflammation or some form of process that's happening at the specific location of where the stenosis is located. And so that has been looked at. And the presence of venous sinus stenosis is thought to increase the risk of rupture in these AVMs. And so that is an important thing to keep in mind. And so, yeah, so those studies are ongoing, though.
I see. Thank you so much.
Laura, I have another question, if you don't mind. What about in other vascular pathology like aneurysm or fistula? So do you think that this is useful, to
Yeah, so we used this technique for a lot of different pathologies. So we did not use it specifically for aneurysms unless this was an aneurysm that was complex enough for us to consider flow, meaning we needed to know if we needed to bypass this patient or not. And so for that, preoperatively, we might get a quantitative MRA to see how much flow is going into the parent artery to help us plan what type of bypass was needed. And so that would really only be the time we would use this for aneurysms. However, for other types of diseases, it was very useful. Fistulas, for sure. The fistula assessment is almost identical to the AVM assessment, where you're checking to see the changes in the flow over time with these embolization sessions. And then the other one that I did not talk about in this presentation because it did not apply, but we have a protocol to look at hemodynamic reserve with this flow imaging, and that helped us to assess patients whether they were good candidates for bypass or not. Specifically, these patients that have intracranial atherosclerotic disease, where the indication for doing a bypass is a little, sometimes a gray zone. And so having this type of flow-based imaging with a protocol like a Diamox vasodilation challenge helped us to figure out which patients were good candidates for surgery. So there's a lot of different diseases that we use this type of imaging for.
Just out of curiosity, it can be used after bypass to assess the patency and the reperfusion. Is it possible?
Yes, it is possible, and it's something that we did routinely. And it's so we would check the flow after bypass surgery, and we would monitor the flow over time. And some patients, their flow, like the bypass itself, may involute, but we can check and see how the flow in the rest of the brain has responded over time. So yeah, absolutely, we do use that for bypass.
Excellent.
Maybe Lola, thank you very much for your nice talk. Just I want to ask the two questions. One is maybe with your technique, any change after the treatment or resection of the AVM? That is one. Another one is how often do you send a gamma knife after the embolization? maybe compartmental embolization is very, very important, I think, because sometimes radiosurgeon doesn't hate to have an embolization, preoperative embolization, because very patchy embolize is very noisy to the treatment, I think. Thanks so
You're
much.
absolutely right. Yeah, for patients that undergo SRS, that's part of the reason why our sample size was so small, is because there aren't a lot of patients that really qualify for undergoing embolization before getting SRS. And so those patients that were in that study, because of the limitations of SRS when you have embolization, I think those patients, for the most part, had not undergone embolization, or if they had, it was only for really high risk things that had been present on the AVM beforehand, because of the issues that you raised. But either way, the quantitative MRA is still useful, in my opinion, to see how the flow changes over time with the AVMs after they've gotten treated with SRS. And now it's not as important to monitor that, because you have not directly changed the flow, but it is interesting to see, once it reaches that complete obliteration, how things have changed in the brain and in the AVM. And I forget your first question. I apologize. That was your second question, which I answered first.
So after the embolization of the nidus, maybe how change of the surgical technique, any change to embolization? Thanks.
In terms of the surgical technique and how it may change after the embolization, it can actually change, because you have, with the quantitative MRA and this type of assessment with the embolization, because I know some people do not like to embolize AVMs preoperatively. That's still an older way of thinking about it, and some people, that is their preference in surgical practice. However, embolization, especially if you can get to some of the deeper feeders successfully, then it can definitely change your safety with the surgery and your thought process of how aggressively you can be operating around the AVM, especially once you reach the deep aspect of the AVM. And so it can change your practice. And then we also would measure the flow in some of these patients, although I don't have this in a study, to see how the blood flow in the rest of the brain has changed now that the AVM is gone, which that's more just a scientific interest. It doesn't necessarily have a clinical correlate, but it does change as the brain has responded to the removal of this high flow disease.
Much. Men.
Yes, and thank you so much, Professor Laura, for your great presentation. And I have our second speakers. I've just received the information that second speaker, Professor Xu Yinghe, I think she's engaged with some clinical duty, and she will try to join if she settle with the clinical duties. Maybe we shall proceed with Professor Kimura's learning point first about your lecture about the usefulness of the CFT for understanding cerebral aneurysm wall properties.
Okay.
Maybe we can ask Dr. Faisal Howard. Thank you very much for joining from Afghanistan.
Assalamu alaikum. Konnichiwa.
Konnichiwa.
Thank you very much, Professor Laura. Exactly, it's very new and advanced information and technique. Thank you for information, and we hope that one day we receive your results and your knowledge sharing with us. Thank you.
Yes, thank you, Professor Esme. So maybe we shall proceed with the Kimura's, Professor Kimura's sharing first.
Okay. Thank you. Thank you. Can you see my slide?
Yes, yes, very well.
Okay. Wait. Oh, thank you again, Dr. Ben, and for giving me a chance to talk about today's my topic about the usefulness of the computational fluid dynamic analysis for understanding cerebral aneurysm wall properties. I'm working at the University of Kobe University here, working with my colleagues. So I work as a surgeon of the cerebral vascular disease, mainly in the clipping and bypass and the CEA. And also I am a surgeon for the umbilical resection for the skull-based malignancy with my colleagues in the head and neck surgeons. And my research is computational fluid dynamic analysis for the mainly cerebral aneurysm. And the rat aneurysm model is my friend, my research. So today's topic is a prediction of aneurysm wall properties. You know, in a single aneurysm has both thin walled area and a thickened wall area. Only even in the single aneurysm have both properties, thin walled area and a thick walled area. And you know, the thin walled area can cause to the high risk region intraoperative rupture. On the other hand, the thick walled area cause to the incomplete occlusion after clipping, or sometimes causing a thromboembolic source, and sometimes cause to the branch visceral occlusion. So it's a prediction. Before operation, you know, if you can predict these aneurysm wall property is very important to perform the safer surgery. So in my university, we performed a CFD analysis for every aneurysm before intervention. So I classified into these 5 grades of the cerebral aneurysm wall properties, grade 1 to 5, depending on the intraoperative findings. This grade 1 shows a very thinning wall area, and grade 3, like just a normal pinky whitish visceral wall. And this is a grade 3 wall. And grade 5 wall is a yellowish and so thickened, like an atherosclerotic aneurysm wall was assigned to the grade 5. I just classified these 5 grades with aneurysm wall properties. And I found this one parameter from the CFD analysis, wall shear stress vector direction variation. This time, this parameter was called wall shear stress vector variation. So it's called WSSVV. This is the name change, WSS direction variation, WSSDV, can predict aneurysm wall properties. As you can see here, this is the intraoperative finding here. This is a color map of the WSSDV. And this thin wall area has a low value area and a thick, a little bit score area in the high value area, And the yellowish, like atherosclerotic thickened aneurysm wall had a so high value area of on this color map you can see. And the two thin wall area and the thick wall area, the quantitatively analyzed, and you can see that these differences are statistically significant. And another parameter, oscillatory shear index, can also predict the aneurysm wall properties I found. And the OSI also using this OSI, you can see this thin wall area had a low value area. On the other hand, thick wall area had a high value area. And also, these differences are quantitatively evaluated, the statistically significant, you can see. And why these two parameters can predict the aneurysmal properties, we searched on the reason mechanisms. And this parameter correlated significantly with each other, we found. And if the visceral wall parallel flow on aside the aneurysm wall or divergent flow makes the unidirectional flow. Where the unidirectional flow goes, the aneurysm wall will be thinning, wall thinning, causing to the wall thinning. On the other hand, where the aneurysm wall flow become rotational, like rotational or convergent flow, makes the stagnated flow, where the aneurysm wall may thicken wall area, like here. So we found these mechanisms. The wall hemodynamics changes may causing to the aneurysm wall properties, wall thinning or thickening. So how you use this CFD analysis to the clinical application to perform the safer surgery? This is just one example. For this patient was a 30-year-old female had a paracrinoid aneurysm. So many aneurysms she had, like ipsilateral MC aneurysm and IC-top aneurysm she had also. And I approached this aneurysm to the contralateral approach to clip the paracrinoid aneurysm, as you can see here. This is a preoperative simulation using the CT angiogram. And this top aneurysm will be attached here, and the backside of the optic field, the surgical field, you will see some small waves behind the surgical field. In the preoperative simulation using the CFD, you see this wave maybe consists of the thin wall area on both WSS-VV and OSI color map you can see here. This wave may consist of the thinning wall area that are predicted preoperatively. This is the intraoperative finding here. I approached to this aneurysm, as I mentioned, to the contralateral approach to the left front temporal craniotomy. In the optic nerve here, the aneurysm was exposed already, and aneurysm is detached from the 𝒂𝒏𝒆 and inverted, and you can see the small tiny thin walled area waves was found intraoperatively. This can be predicted as more carefully dissected around the structure, so to avoid the intraoperative ruptures. So after clipping, the endoscope was confirmed the complete occlusion of the neck. So it's a help to the intraoperative rupture. I mean. So this is a case with the endovascular treatment. The patient had a small, about 7 to 8 millimeter MC aneurysm. The patient was coiled at this and then, and this is a preoperative rotational DSA and the post-operative one here. As you can see that this is the LSA was here, but the post-operative, this LSA disappeared, maybe occluded intraoperatively. The patient had a minor disability post-operatively. The patient suffered the right hemiparesis, mild, and the DWS showed the high signal area and the coronal radiata here. And this is a CFD analysis here. This aneurysm had I think that this aneurysm had a atherosclerotic thickened wall area, entire of the aneurysm wall, posterior, backside of the wall, sorry. here you can see the intraoperative manipulation, the coiling in the inside the aneurysm wall, aneurysm lumen, according to their maybe embryos. Originally, this aneurysm had an embryos or atheroma inside the aneurysm wall. Intraoperative manipulation may cause to the thrombus. Migration of these thrombus may cause to the LAC occlusion, I think. So aneurysm wall properties, wall thickening and thinning could be one of the indispensable factors for the safe surgery. Preoperative CFD can work for it. Thank you for your attention. Thank you. Is there a question? Thank you. Ben, please.
Yes.
Thank you.
Professor Kimura, as always, I always get inspired by your lectures, and very interesting lecture about your theory and also how you study it. I would like to ask about in your proposed mechanism with the stagnant flow and also the unidirectional flow, and can it be generated by the CFT program with the flow diagram to prove that your postulation about the stagnant flow, so the rotational and also the divergent flow is evidence on the CFT program. Is it possible to show this in the CFT program?
Yeah, thank you. Yeah, good question. Thank you for your good question, Ben. So it's a commercially available software. Just we did not know about the in detail inside the aneurysm calculation, so we should know about it. But yes, I hope we could know, but now we can't know about it in detail how we calculate it. But as a result, I found the result of the CFD analysis corresponded to the aneurysm wall properties. Yeah. And finally, yes, and these OSI also show the directional flow and vector changes of the wall shear stress. Also, and WSS direction variation also show the angle changes during the one cardiac cycle of the wall shear stress. The same meaning. The OSI in the WSSVV has the same meaning. They both say the directional changes of the wall shear stress during the one cardiac cycle. So that's why both parameters can correspond to the aneurysmal properties, both. Thank you. It's a very important point.
I see. And another point I want to raise about is the study of the color of the aneurysm. So I think it's hard to quantify, but there is some study using the photometry or studying of the wavelength that may able to quantify the color of the aneurysms. So maybe it's possible that you can quantify the wavelength with the color. Yeah.
Weakening.
Yeah, wavelength. So it defines the aneurysm. So what does it mean by red? What does it mean by pink? What does it mean by white? Yeah. Just some comment on the color for the aneurysm. Maybe it's possible in the future to quantify the color.
Yes, that's a good point. So the color is just a correlation of the aneurysm wall, not always correlated with the aneurysm wall thinning, wall thickness. So we have to know about we should perform the further research to analyze the aneurysm wall thickening, aneurysm wall measurement of the actual aneurysm wall measurement to compare the CFD analysis and the actual aneurysm measurement of the size is an important point. So now I'm thinking about it. So using another modality to see the aneurysm wall measurement to compare to validate the CFD analysis result. Thank you for your comment. Thank you.
Thank you.
Yeah, please.
Thank you, Professor Kimura, for a wonderful presentation. I have one question that do you use CFD to evaluate the rupture risk and make the implication on the treatment indication for aneurysm?
Yeah, good point. So if we could use this technique to predict the aneurysm rupture, it's my future dream to do such a to do the CFD analysis for the patient. In the normal healthy patient has some recently detected unruptured aneurysm on the screening MRI. So we recommend the patient usually the more than according to the size of the shape of the we recommend the patient to receive the surgery. But now, in the future, I hope that this received analysis can say more accurately to predict the future aneurysm rupture. It's a good point, but now it's not completely accomplished. Thank you.
Thank you, Professor.
Future dream. We should collaborate each other to see the result. Yeah, thank you.
I hope so.
Yeah, I hope. Thank you.
Professor Kimura, I really like your technology and technique.
You.
You grade it nicely from grade 1 to grade 5. But I have one technical question. If you have done this analysis prior to surgery, will it help you to plan your approach to the aneurysm and to place the clip, because you can see the thin wall and thick wall. If you wrongly clip and the thin wall is not included, it's gonna be ruptured. And then if you wrongly include the thick part, and there will be thromboembolism risk. So does it help in terms of your strategy? Probably you can share with
Yeah.
the generation how to use this.
Thank you, Azmi. Very good points. Good question. So, preoperative CFD. According to the preoperative CFD, I changed my strategy. How I dissect around the neck, how I dissect the dome, and of course, as I mentioned, in the femoral area may cause the intraoperative rupture. So before approaching to dissecting the femoral area, I need to secure the parent artery, of course, like a ruptured aneurysm. Even I treat the unruptured one, but in dissecting the femoral area, just like a manipulation is just like a ruptured point. So in approaching this femoral area, I always secure the parent artery first. So and for the second wall area, and as you mentioned, that may cause to the intraoperative, thrombus, maybe. So in the clipping is to avoiding the occluding the second wall area a little bit away from the parent artery. May cause to the thrombus, migrate the intraaneurysm atheroma. So to avoid such a complication, to think about the clipping placement of a clipping a little bit away to the very thickened area is important. Sometimes causing to incomplete occlusion. So yes, thank you.
Thank you.
Good point.
Thank you. Kimura-sensei, you attended the MM conference till today.
Yeah.
So in the conference, is there any discussion about prevent the future rupture or with CFD research?
Thank you very much. So unfortunately, in this conference, I didn't talk about the CFD, just about using to avoid to regarding the bypass occlusion, intraoperative occlusion in bypass surgery. So not CFD. Thank you. Next, I will talk about it. Thank you.
Okay, good, thanks.
Yeah. Thank you. Thank you for your comment. Please, can I give a comment? Question? Please, thank you.
Please unmute yourself.
Please unmute yourself. Thank you.
Yes, thank you very
Thank
much.
you. I can hear you. Thank you.
Thank you, Professor Kimura. As you know, this advanced technology and information is very useful for us, and but unfortunately, we haven't the possibility to work on it, and we are looking that's if possible to send some young neurosurgeons for training and for practicing with you, and then with Professor Kato, and then returning back to our country. But nowadays, unfortunately, it's very difficult. Thank you very much.
In the future, I hope we can do so. We also,
Okay, thank you.
we hope,
Thank you.
probably with you. Thank you.
ありがとうございま
Thank
す。
you. Thank you. ありがとう。Thank you.
ありがとう。
ありがとう。Thank you.
Maybe I think Laura, I think some similar to the AVM treatments. So you need a CFD knowledge.
Like Borussia stress.
Yes. Laura, any question to Professor Kimura?
I do actually have a question. It's not something that you directly mentioned in your presentation, but your presentation was wonderful. I wonder if there is a way to use this technique for CFD to look at aneurysms that have been treated endovascularly with coiling to get a sense of like which ones are going to come back, for instance, because it's a little bit more challenging to control how you're treating with the coiling compared to how you mentioned how this has changed your technique surgically. But I wonder if it could at least help predict which aneurysms may not respond as well to coiling.
Thank you, Professor Laura. Very good questions. So, in my university hospital, just launched the CFD analysis for the case with the endovascular treatment. So we have not accumulated enough sufficient volume to see the result after the embolization. So, but in the future, the coiling to prediction, using the coiling treatment, maybe after the coiling, the aneurysm maybe recur after treatment. So to prediction surgical recurrence, recently with flow diverter, of course, we just launched to prediction of the recurrence of the flow diversion by using the CFD. In the maybe future, we can announce the new data. Thank you. Thank you. Good question.
Ben?
Okay.
Yes. And any comments from Laura? If no, I can see that Professor Xu Yinghe is here. So she's back now. So hello, Professor He.
Hello.
Hello.
Sorry, so I'm negative. Sorry.
Yeah, maybe we can proceed with your presentation about the complex AVM cure for transarterial and transvenous approach.
Okay. Can you see my presentation?
Yes.
Okay. So I will share the topic is complex FM carried through transarterial and transvenous approach. I'm Xu Yinghe. I'm a doctor of the second People's Hospital of Guangdong. So we know to treat the FM, we can transarterial and transvenous, transvenous. So I see from the 2010, and the first case was reported to treated through transvenous. So in China, we use transvenous approach to treat FM about in 2000, I think about 5 years ago. So we just think to transvenous approach to treat MM is very dangerous. Very dangerous. So we at first we can't to treat MM transvenous, but from more and more report to show it's a safe approach, and we can see in this report they say about 13 cases of embolization where a venous approach has been reported have been reported with complete closure of the nidus and the few complication. So from this report, we have some confidence confident to treat FM through transvenous. So at first, we just treat some venous located in tip and or fungulation areas, or some largely unruptured FM or ruptured FM. Gamma doll is not the first choice. And the transarterial approach is very difficult or impossible. So, and the training venous appeared clearly and can be approached. So for this case, this is a small ruptured FM in the basic ganglion region, and have only one training beam. So we think this case is very fitable for transvenous approach. So we put marathon and ACL10 microcatheter approached the nidus through the training vein, and we put some coins through the ACL10 to prevent the backflow of onus, and inject onus through manus until onus diffuse into the nidus completely. So in this case is very the result is very good. We can show after embolization the FM disappeared, and the people is very no complication. So this is another case. Is a ruptured FM in the basal ganglia region and have only one training gym. But the training gym is very total. But we think is also can be enter and approach to the nidus. So this is the sandy graph of FM. We can see we put sonic and ACL10 approach the nidus through the training vein. And we can show just after put the coins, we put the onus through the sonic, and the onus injected into the nidus. So this is the radiograph after embolization, and the shoulder FM disappeared completely. So this is the radiograph sandy radiograph after embolization. And is the follow-up after 2 months. The FM is not the result is very good. And this is another rupture FM in the brain stance, and have only one training beam. We can show. This is the DSA, and we showed So for this case, we want to treat this FM through arterial. It's very difficult, and will have very I think we'll have the complication. So we just think it's very suitable for to use transvenous approach. So this is the SAND regraph, and we we also put sonic and SL10 approach the nanus through training wing, and after putting the coins, we inject honest so the sonic until the honest differs into the nanus completely. So this the radiograph after immunization showed that the FM disappeared completely. And this is SAND radiograph, and I have 10 months follow-up. The result is also very good. So this is a case of FM in the left corpus callosum patient. So it has a hemorrhage, and we think this kind of MM is also suitable for to use transvenous on approach. So this in the SAND radiograph, and we put the medicine through we put a medicine through trans anterior, and to we put a next medicine through venous. So and headway 17 into the vein, and after put the coin, we have after plugging, we have a silver. We put 2 microcrystal to the vein. So after the put coins, we just put we have the super selective angiograph with FM with medicine show there's no contracts medial flow into training vein. So then we begin to inject honest. And so after inject honest, we have a super selective angiograph shows FM disappeared without early vein appearance. And SAND radiograph shows the ACA was kept intact, and LM completely disappeared. So this is the 8 months follow-up. So we just have some experience of transvenous approach to treat LM. So we began to treat some complex LM through transanterior combined with transvenous. So in 1 year, we have treated 18 complex FM through transarterial combined with the transvenous approach. This is also a ruptured FM in basal ganglia region of multi-tenors feeders. But because of this FM have many these chainless feeders, and the is bigger than the last one. So we think we should transarterial approach of embolizing at first. So we have embolization with glue through a bunches of arterial cranium arteria, and also put glue through bunches of MCA, After embolization through transarterial approach, we can show the FM became much smaller, but we think this is not safe, so we decided to treat it with through venous approach. Also, we put the marathon and the SL10 into the venous and put coins and inject honest through marathon, and the cast down honest DCL showed the FM completely disappeared. And the CT scan showed their CT scan, and there are no additional neurological deficit. So the second case is the patient have vision blurring for 2 months, and there are large FM in deep frontal lobe. This is the DSA showed the very large. The FM have a very large velum and have multiple tenous feeders. Have 2 main training wing, and we just think would this type of MM would later symptom of high ICP, but we just think we need to treat this MM at first, because there are no other reason to make him have this high ICP. So we just treat the FM at first through arterial approach. After the transarterial embolization, we can show the FM became much smaller. But we can see the symptom is just improve transient, and then worse again. So we think we should to cure this FM, because the wing had a local stenosis. At first, we to put a balloon and to treat this stenosis. Then we show this the wing, and we also put the marathon and the SL into the venous, and put the coins, we inject honest, and we can think in this time the wing still appears early, and we inject again, inject continue, and the honest begin to diffuse into the feeders. So after the injection, we have a DSA again, and we show the FM completely disappeared, and without early appearance of wing. This the CT scan on the second day after operation, and no hemorrhage vision appeared significant. So the second case is in the left photon FM is also a big FM and have a hemorrhage, and we can show their feeder MCA boundaries. That is a feeder, our feeder in the MCA boundaries, and we can see this. There are false venous aneurysm. We treat this MM at first through arterial approach. So this is after arterial embolization, we can show the aneurysm. The aneurysm is also not disappear. So we think we need to cure this MM. So we use transvenous approach, and also put coils and inject honest Let's show in this time we can show they also have a little FM result. So and we inject honest continue, but honest count not diffuse into this part of nitrous, and so we use trans arterial amylase again. Then we can show this time this area showed MN disappeared completely, and this is the Sandy angiograph. This is the 3 months after amylization. 3 months follow up after amylization. The first case is FM in the left parietal local, and we amylized through arterial approach for several times, but it's not cured. So we think we should use transvenous approach to cure this kind of aneurysm. Also, we put sonic and SL10 into the venous and put coils and inject honest. So this is the 1 year follow up after amylization. We can show the FM disappeared. This case is a children, 3 months infant, gallon FM and have a hemorrhage, and so the DSA showed that the FM nidus was spread by branch of bilateral 𝒂𝒂𝒃 artery and the PCA, training into the great cerebral vein. We just treat this FM through arterial at first. After the arterial amylization, we can show they also have the FM result. So we use transvenous approach, put the marathon as SL10, and put inject honest. And then after amylization, we can show the DSA showed FM nidus disappeared after amylization. This is the Sandy. Okay, the 1 year follow up showed the result is good. There are no FM recurrence. The next case is a 1 year boy and also had a gallon FM and hydrocephalus onset. DSA showed the FM is also, and also we seen they have many totals and smaller feeders of PCA and trained into strange signals, and so we have 3 times for 3 times through arterial amylization. So this is the third time arterial amylization. We can show the MM was much smaller, and the children had hydrocephalus improved significantly after 3 times trans-arterial amylization. But 6 months follow up after 3 times arterial amylization, we can show this is the DSA, and the MM became bigger. So we suggest the children's parents to treat this MM through venous. So we plan to reform transvenous amylization, and this is the Sandy graph showed there are two training venous distenders. So we put 2 2DA local 2DA into the sinus, and we put 2 microcatheter into this 2 training wing, and put 1 microcatheter to put a coin into this 2 wing. Then we inject all this through the sonic. So after the injection, we can show the FM disappeared. We put out the microcatheter. So let's listen D. And this is 3 months follow-up. So we think to the transarterial compared transvenous maybe is a good treatment for this kind of complex LM, but they also have some tips in the treatment. We think we need to treat this kind of LM through transarterial at first, so they will be safer. They will be safe to in transvenous approach. So we think with the understanding of this kind of FM structure, the indication of venous approach may be more and more extensive, and the carefully and sufficient pre-operation imaging and aneurysm is the key to reduce complication and obtain the good prognosis. But we also need fully complication with the patients or the risk. Thank you.
Thank you so much. I think there's a Kimura, yeah. I think there are so many questions.
Yeah. Thank you. Thank you. Jin. How can I pronounce your name? I'm sorry to pronounce you difficult. Very fantastic, excellent presentation to do the transvenous approach to occlude the nidus of the AVM. It's a very new technique to treat the AVM. At first, I understood. I understand the transvenous approach can be one option to treat the single option for the treat the AVM, but you mentioned transarterial approach first as much as you can. So after that, we failed to treat the patient with a ruptured AVM. So next option to choose the transvenous approach to cure the nidus totally. I understood. Thank you. But so my question is, when you decide to perform the transvenous approach to occlude the nidus, after several multiple trials to occlude the nidus by a transarterial approach, when you need to choose transvenous approach? Thank you.
So for this case, many of these cases have rupture. Ruptured FM. We need to cure. We need to cure this kind of FM, and so we treat this FM through transarterial at first. We can say we count to treat the FM through arterial. We will think about to use transvenous.
Yeah. I assume that maybe after several trials to occlude the nidus by a transarterial approach, after you lost every main feeding artery to occlude the nidus. After that, you can approach to the transvenous approach to access to the nidus, right? Is this right or not? If you have some more remaining arterial feeder can be approached by the intravenous transarterially, you can access to the transarterial embolization first. Remaining feeder can be detected on the angiogram. You can choose the transarterial approach more trial using the transarterial approach than the transvenous approach. But after several trials to occlude the nidus transarterial approach, after that you can not find out any artery can be occluded. After that, you can try to the transvenous approach to occlude the nidus. Is this right?
Yes.
Okay. Okay, I understand.
Yeah, but we just think danger is more danger transvenous approach than transarterial approach. So we just use transarterial at first. Yeah.
Yeah. Thank you. Very nice approach. Yes, thank you. Is there any other question? Yes.
Yes. Dr. Hayes, thank you very much for your nice presentation. Just I want to ask, so what's the structure of the nidus? You can choose a transvenous embolization, and also how you can differentiation. You can use sometimes coil or sometimes the onyx. So just you can tell us step by step. Okay, please.
We put coils as more as possible. So we just want to block as possible. So we put many coins in the wing, just to invent the honest flow back. Yeah.
Okay. So thanks, Asmin.
Zuying, I have a lot of questions before, but after I read your last two slides conclusion, then I understand that transvenous is actually complementing after transarterial. I have two questions, in fact. Number one, you mentioned the marathon microcatheter. So does it specific for transvenous, or it can be used for transarterial as well? Because I understand this marathon microcatheter is very flexible and suitable for very tortuous thin vein. So that is one question. Number two, in your mind, is there any possible indication there where you can just straight away use transvenous technique rather than transarterial first, then followed by transvenous? I mean, is there any indication that you can straight away use a transvenous approach?
I'm sorry. Can someone can you repeat? I don't.
Okay. Okay. The first question is the marathon microcatheter. So is it a specific for transvenous approach?
What kind of microcatheter?
The marathon. You mentioned marathon microcatheter.
I used the marathon at first, but then now I use sonic. I never use sonic. So because in the first at first we use the medicine for sometimes we can't put out the medicine. We need to put the medicine in the body. So and then we change to use sonic. The sonic can put out easily. So we use sonic now. We like to use sonic. Yeah.
My second question, is there any indication where you can straight away use transvenous technique without transarterial first?
Um,
You mean the
他问
transvenous only? You mean?
Yeah.
他问就是为静脉栓塞，就是只用静脉栓塞有这个情况吗？
Oh, okay. So, for first, some cases we use the albumin is small, and we count to treat this LM transarterial. We will use transvenous without transarterial.
Okay, all right. Okay, thank you.
Any other questions from the floor? If not, can I ask one very short question at the end? And I want to ask about in your center, so because you have so good expertise in the embolization, so how about the surgical treatment? So in what cases would you prefer surgical treatment, the excision of the AVM instead of the embolization?
Surgical.
Yeah.
Oh, open.
Yeah,
Yeah.
in your center, yeah, because you do the endovascular so good, yeah. And then, what case?
So in what case maybe for rupture FM and some I think some photo or not in functional lobe. Yeah.
I see. Thank you. Okay, if there is no further questions, shall I pass the platform to our chair, Kimura Sensei, again?
Thank you, Ben. Okay. Today we are Professor Okato, could you give me us a comment? Finally. Thank you.
No final. Maybe Kimura Sensei will give the last comment. I think.
Okay,
Today's two topics is very much interesting talks because of the just related with the flow. It is very important for AVM because just reduction of the flow is most important thing to cure the AVM. Maybe the staged, or I think this combination of the radio surgery, because recently many of the patient doesn't want to have the open surgery. So I think maybe in the far future, I think it will be cured by drug. Hopefully, I think. So, but I think the embolization technique and also the device and the method and the glue is improving the day by day, I think. I think that you should have more idea to cure the itis, I think. Thank you very much.
Thank you. Yeah, great comment for us to, finally. Yeah, good point. So we learned a lot regarding the AVM, quantitative evaluation of using the MRA. So a very important concept. To accurately measurement of the AVM, the flow is very important to predict the future risk of rupture maybe, and to perform the safe surgery preoperatively, we should know about it. So important point. So I hope I could this measurement using you mentioned that we don't use the gadolinium, just use without the gadolinium, we can do this technique using the ordinary MRI instrument. But yes, I will try next time. So in the future, we have to read your paper. Yeah, excellent paper in the stroke published read in the 2015. Yeah, first, yes, very nice. Yeah, I learned a lot. Thank you very much. After that, there are yes. Sorry.
Please, go ahead.
Yeah, thank you. So after that, surely agree. So very nice presentation. So transvenous approach is a very new concept for us to the, yeah, as I mentioned, the trans-arterial first we should do. So after that, we can try the transvenous approach to cure the ruptured AVN is a very important point. We have to know, we have to learn much more before try to in the actual clinical case. But the important point, thank you for your excellent lecture sharing up with us. Thank you. Okay.
Maybe we can take one last comment from Dr. Azmi, please.
Okay, thank you very much. I think this collaboration between ACNS and ISMIN has bring a lot of new ideas, especially today, because we have seen a lot of new technology that probably available on certain part of the world, but spreading the news, spreading the knowledge, make us think that the world is, I think, interconnected. I think this is a very good. We hope that this collaboration will be continue in the future, and we hope we keep in touch, everybody. So we will see you again in the next seminar or maybe a physical meeting. Thank you very much. Thank you, Professor Eko Kato,
Very much.
Professor
Thank you.